Okay. Good morning, dear colleagues. We are ready. We are very glad to see you on our lecture. This is the third lecture in a course of lectures from our colleagues from University of Leeds, organized by Professor Devід Джейн. With the support of Fund of the President of Ukraine for Education, Science and Sports. I would like to invite Professor Devід Джейн. Professor Джейн, please tell us a little about what we'll do then. You can introduce our lecture.
Thank you very much, Ruslan. So this is the third in our series of lectures that we've lined up for you. We're addressing several important topics in general surgery and vascular surgery. Today, the lecture is going to be delivered again by Patrіка Coklin, and we're going to dive into some more detail around vascular surgery. So over to you, Paddy.
Please, we invite Mr. Patrіка Коклін with his lecture, and I have to tell that Mr. Patrіka Коклін is a great friend of our university, and he was in Ukraine several times. So please, Mr. Coklin, the floor is yours.
Ruslan, many thanks. And as always, it's a pleasure to talk to friends and colleagues from Czenitsky and the medical university there. And a slight pivot from last week, which was all about medical imaging in arterial disease. I'm going to use vascular surgery as a theme for really to focus on medical training and how sudden conflicts, sudden issues, sudden emergencies, sudden pandemics will can affect and actually positively affect how we train our trainees in general, but surgical trainees in specifically. And there is some evidence, there is some science within this, but it's more really a bit of a journey that I've taken and vascular surgery in the UK has taken from the point of view of how we've progressed with regard to education. And I know this sits is a very core part of the medical university's blueprint really over in Czenitsky. I've been fortunate to come and visit the simulation center there on a couple of occasions. So it seemed the right thing to do really to sort of focus a bit on education due to the links with the university in Czenitsky. I'm going to look at a bit of undergraduate training. I'm going to focus primarily on postgraduate training and surgical training. I'm going to look a little bit around how the common ground between us here in the UK and in Ukraine and some common links perhaps. And why does it matter? Well, I think having been over to Czenitsky and the medical university there, I think the questions that when I've been talking to people that you're wrestling with about how you maintain the training in doctors in a world that is changing and in an environment that is difficult. And I think some of these are the questions that we've been posed with and are trying to address as well in the UK. And so really what my talk will look at is how we go from this bit of training from hundreds of years ago, where this is a balloon amputation, it would have to be a balloon amputation as a vascular surgeon, and how people were trained and taught about that versus what might be here in the future with immersive technology. And really, this was how surgery was taught in the hundreds of years ago. This is almost a theatre with a lecture theatre associated with it, and you can see that surgeons here have travelled far and wide to watch operations being undertaken. No laminar flow, no real probable sterility, and so it really is beyond comprehension, really, that this was, in the current world that we live in, that this was how surgery was taught. But we learn, we innovate, and we move forward. And so the first bit of my talk is really to reflect about how we've got to sort of medical education here in the UK. And really, this has been a journey probably over about 150, 160 years. And I've just identified here really three key dates or time periods that I'm going to reflect on a little bit more in the UK as to how they have evolved, and these specific time points have evolved how we teach doctors both at an undergraduate and a postgraduate level. So in 1858 in the UK, the Medical Act was put into through Parliament, and this had a number of very specific key factors that have led to really the first part of how we've evolved our medical education. It created a register. So what this meant was that anybody who wanted to practice as a doctor needed recognised qualifications and needed to register as a qualified doctor. And because of this and because of the qualifications required, medical schools were required to meet recognised and accepted standards. So alongside this medical register was the establishment of our what is now known as the General Medical Council, which is our overarching body that oversees our practice and our registrations and really looks at standards. And the GMC is still running today. What the Medical Act did as well was to really align training into a single system and brought together a lot of fragmented systems that were already in place to sort of try and train doctors. So there was a standardization of qualifications. And with that, therefore, led to recognition of medical schools, so approved medical schools. So medical schools needed to go through a system to get approval to then meet the standards that were required for medical register. And this formal medical school education meant that there was a move away from a more informal apprenticeship type training. So it was really the formalization of medical training, qualifications, and then recognized standards. And therefore, as such, medicine became more professionalized with clearer undergraduate and postgraduate pathways. But also with that came a degree accountability, both to the medical council, but also probably more importantly to patients. And then Abraham Flexner, he's an American and was an American that was interested in medical education, and really his work in the early 1900s led to sort of the evolution of the curriculum for medical training and medical education. He put forward that he felt that there should be a strong grounding in the basic sciences, and this really led to the development of the medical training that I went through at an undergraduate level, where your first couple of years were very much around the basic sciences of anatomy, physiology, biochemistry, and pathology. I think a lot of us will remember those going through the textbooks, books in those days, not online books, but actual books, and learning all those things that were required to get through what was our second MB. He felt that there should be an alignment of medical schools with universities, and that there should be an evidence that what we're taught and what we learn should have an evidence base behind it, and which really led to the emphasis more on levels of evidence and research within medicine. He felt that after the basic science aspect, that there should be a structured clinical training pathway so that there was a recognized experience within hospital for undergraduate training. And he felt there should be standardized admissions and curriculum. So the medical schools maintained a consistent academic standards. And with this should be regulation and accreditation for the quality of medical education that was delivered. And these sort of core features of what became known as the Flexner model really were taken up in the UK and became the bedrock really of training or medical training within the UK. And so in the UK for many years, this was the path that we all that training developed. This was really time-based rather than competency-based. You would have usually 5 years as a medical student. You would then enter into work in a hospital, initially having a pre-registration year as what we called as a house officer. And then once you'd completed your year, you then were registered with the medical council and then went through a series of incremental posts of seniority in the specialty or specialties that you were keen to explore. This doesn't take into account community or primary care medicine, but you would do a time as a senior house officer, registrar, then a senior registrar. And really, this was very much time-based. You would spend time as a senior registrar waiting for a consultant post to become available. And this could be a long period of time. So it wasn't really competency-based. It was more just you were time-based and waiting for the next consultant post to become available. And really the way that certainly surgery was taught probably in those days was more of a see one, do one, and teach one path, which has certainly changed in the way that we teach our surgical trainees now. So the early 1990s in the UK really led to a major change in how we trained our doctors, both at an undergraduate and at a postgraduate level. This was a report for our medical council, and this is a focus on undergraduate training only. And the aim was to move away from a heavy sort of lecture-based, discipline-separated teaching to a development of a more integrated curriculum. And so what they were trying to move away from was that heavy anatomy, physiology, biochemistry being taught in silos, and maybe looking at more integrating anatomy, physiology, biochemistry into a system-based learning. So the aim was to look more at this sort of problem-based learning approach, but also with a focus on additional skills that are becoming increasingly important, and the skills that you need as a doctor when dealing with patients. So there was a focus on communication skills, there was a focus on ethics, there was a focus on professionalism, and there was a focus on lifelong learning. So this was the undergraduate training. Similarly, there was reforms that were undertaken for postgraduate training. And the aim of the Kalman reforms, this is a picture of Kalman himself, were to provide a more structured approach to medical training that was standardized to reach a specific qualification. So essentially for completion of training. So you would get a certificate of completion of training. I use the word efficiency. The cynics may say that this was an aim to get people through quicker and get more consultants into practice to help with our increasing waiting list, etc. But the key things, and I'll show you a schematic diagram of this shortly, was it was a merger of the two registrar roles. You will remember from that previous slide that I showed that there was a house officer, a senior house officer, registrar, and a senior registrar, and before a consultant. So there was a merger of the two registrar posts into a specialist registrar grade. There was very much a focus on the curriculum, so curriculum delivery and development was important. And the training became more competency-based rather than time-based. And there were very specific competencies that had to be achieved that were aligned to the curriculum. So the training was definitely shorter. It was definitely more organised. And as I said, it led to the award of a CCST, which is a certificate of completion of specialist training. And this is what Kalman training looked like. Quite similar to there was some similarities to the diagram that I showed you a short time ago, that students would come from school, they would be accepted into medical school and undertake a period of training, undergraduate training of between 4 and 6 years, depending on their personal circumstances and the university that they went to. They would then leave medical school with a medical degree and enter into a single year of pre-registration training, still known as the pre-registration house officer year. Once they completed this, they then were registered by the medical council and got certification. They would then enter into a senior house officer years. This was anything between 1 to 4 years, usually, with a series of usually 6-month rotations. And during this time, it would be expected that they would sit some postgraduate exams that were run by the Royal Colleges. There would then be a application process that used to be regional. So if I work in Yorkshire, so I applied for a specialist training post within Yorkshire, and they would then go through their more specialist training. So this was the senior house officer training was more generic. So as a surgeon, this would be 6-month training programs in, for example, orthopedics, ENT, urology, plastic surgery, etc. And then you would enter into usually a 6-year period of specialist training in your chosen subspecialty. So if you were an orthopedic surgeon, this is where you would just do orthopedic training. At the end of this, you would have met certain criteria set out within the curriculum of the specialty you were training in, and you would be awarded your certificate of completion of specialist training, which would then allow you to move into consultant practice. So where are we today? So that was in the early 1990s. We're now 30 years down the line. And from the point of view of undergraduate training, there are now 47 medical schools in the UK. These are shown here on this map. So it's been a significant increase in the number of medical schools that are now in the UK. And the driver for this has been to increase the number of doctors that will be in the workforce in the UK. There's a recognition that the UK is probably under-resourced from the point of view of doctors that are available. But naturally, it takes anything between 10 to 15 years to train doctors. And so there is a lag, still seeing a lag in the number of doctors that are coming through in the UK. There has been a further change in our medical education from the point of view of undergraduates. The medical school course is now usually at 5 years, but there is an ability to take an extra year where you can do what we call an intercalated degree, which is usually a Bachelor of Science in a subject that is aligned to medicine, for example, psychology or anatomy or physiology, sports medicine, those sorts of things that will complement your medical degree. There's been a move to more of a capability and outcome framework, so very much looking at problem-based learning, so integrating different aspects of anatomy, physiology, biochemistry to look at a slightly more systems-based approach to learning. Simulation has been very much integrated into training from the point of view of history taking and examination, and that most universities now will have a simulation suite. And Ruslan and the team came to see the simulation suite at the Leeds Medical School when they visited us a couple of years ago. And there's now been a move towards standardization of assessment, with OSCEs being the key assessment model that is used. Prior to that, it was the more standard sort of short cases and long cases, which were probably open to variable methods of assessment. And there's been a widening participant agenda. There's a move to diversify the entry into medical school, including at graduate entry, and those areas that have been people that have found it difficult to get into medicine for a number of reasons. So definitely a widening participation agenda. And from a postgraduate aspect, there have been some subtle changes in how a doctor will get trained as a postgraduate. Very similar, you can see that the medical school aspect, the time has stayed very the same, but there's been some more refinement really to the point of view of the training as postgraduate. So we have got rid of the house office, the pre-registration house officer year that was a 1-year program, and converted this into a foundation program, which is now 2 years. And within those 2 years, our doctors undertake 6 4-month placements in a wide variety of medical specialties, which is felt to give them a wider view of being a doctor, but also to expose them to a number of other different specialties that may then lead them to go into different career pathways. This is very much a surgical based slide. Once you've done your 2 years of foundation training, you then, through a competitive interview of national selection, will go into core surgical training. But again, this is a 2-year program of 4 6-month posts, where you'll get a flavour of a number of different surgical posts. It could be orthopedics, plastics, urology, vascular, general surgery, emergency medicine, and those sorts of things. And then again, through a further competitive interview, you then enter into a 6-year higher surgical training pathway that, at completion of some examinations from the Royal College of Surgeons, ends up with you being a consultant. There are different pathways for academic clinical training within this, and there are ability for you to take time out of this training program to do academia, to do other aspects that are important for your training, be that in leadership, in management, and in teaching. And within each of these years, there's a yearly assessment system. It's called an ARCP. And within this, there are a whole number of things that are required for you to, for the trainee to develop a portfolio of evidence. So these would include work-based assessments. As a surgeon, these are procedure-based assessment for index procedures. You're asked to develop some multi-source feedback, so from your peers and your trainers, to get feedback on your practice. There are obviously examinations. I'll touch on those a little bit later. And there are other methods of assessment, and all these are brought together by your educational supervisor. So every trainee has an educational supervisor who then writes a report that is then assessed by a panel of trainers regionally that will review your competence for progression. And so this is where we sit at the minute from the point of view of medical training, but specifically surgical training. I'm now going to move on to sort of really to reflect on how perhaps events that have happened over the last few years have changed how we deliver some of the education that we do. For us, COVID had a huge impact upon how we delivered education. I'm going to go through some of the things that we developed in vascular surgery. But obviously, I've also seen my time over in Ukraine that the impact that the war has had on how you develop or try and deliver education within Ukraine. So for us with COVID, there was it literally happened overnight. We went into lockdown, and that had literally within hours we had to change everything that we were doing. From an undergraduate point of view, clinical placements were cancelled because didn't want to expose the students to unsafe environments, but also it meant that we could focus very primarily on managing COVID. The university shut down. Exams were moved online or postponed. Final year students were deployed as more quickly into working within hospitals, and teaching was moved remotely. From a postgraduate point of view, we stopped all elective surgery, and therefore that meant that there was a lot of training that was lost, but recognition that would have an impact later on once we got through the pandemic. Our assessment panels were sort of really only on an emergency basis, and a lot of our postgraduate trainees, surgical trainees, had to pivot into different specialties. So a lot of them went to the intensive care units or into acute medicine, and they had to learn very quickly new skills and new techniques, but without that sort of structured feedback that they were used to. And that had a significant effect on their well-being. And we coped, but it was difficult. And these were the things, having reflected on what I felt that it forced us to learn. It became clear that simulation was underinvested. It showed that perhaps we hadn't quite got the skills into our trainers that were needed from the point of view of remote facilitation and the well-being of trainers. And so that was something that became evident. And there was a lot of pressure, silent pressure that was taken on by the trainees. But I think for me, one of the things that we developed or were forced to develop was the digital delivery of education. I'm going to touch a little bit upon that. And it opened up a lot more doors for us, for those who were slightly digitally illiterate or digitally incompetent, that we had to learn, and we had to learn quickly. So I'm going to focus on what we did in vascular surgery. At the time, I was the chair of the Education and Training Committee of the Vascular Society. And so it became very clear from my perspective that we had to pivot to a different model of delivering our education. Before I go on to that, I'm just going to talk to you a little bit and provide some context about what we were providing already in vascular surgery. So vascular surgery moved away from general surgery, became its own specialty about 10, 12 years ago. And when we started as a specialty in our own right, we developed our own national training program. Some of you, I think, have heard me talk about this already. But what we delivered was for each training year, so in the senior trade, so the specialist registrar training, so that is years 3, 4, 5, 6, 7, and 8, so 6 years of training, we'd already developed a 2-day residential course for each of our national trainees. So every trainee in our national program every year went to a residential course. This was led by senior faculty, and really the aim was to support trainees through each step of the training and to provide that mentorship by senior national vascular surgeons throughout. And this is what our program looked like. It was this is some photos taken from the Aspire 6 course. So those in their third year had a very basic introduction to vascular surgery training. Those in their fourth year was a cadaveric course on basic operative techniques. Those in year 5 had some more advanced training, predominantly in some of the minimally invasive stents and angioplasty techniques that we use in vascular surgery. Those in the 6th year had a slightly more advanced cadaveric course looking at aortic and head and neck work. Those in Aspire 7 prepared for our national exam, and those in their final year had a preparation course for independent practice as a consultant. So this is when I was working in Cambridge. This is our cadaveric lab. These are some of the simulation models that we were using, and this was some time ago. All these 3 are now consultants in the UK. So that was what we had already. It was felt to be the gold standard for surgical training in the UK, and we were very proud of what we developed. And then COVID came along, and as we can see now, we're on Zoom, but Teams and Zoom became our best friends. We learned a hell of a lot, I think, over those first few weeks for us about how we can engage with digital and technology and sort of use online methods for education. And so what we very quickly pivoted to was a series of online lectures. So we went into lockdown at the end of March, and this was our first weekly lecture, which was usually done on a Monday night at 7 o'clock. So within 4 to 5 weeks, we'd developed a series of weekly hour-long teachings that were actually in the beginning were really well viewed and well attended. We were getting well over 100 people each Monday night to come and listen, and we started to go through the syllabus or the curriculum for vascular surgery and designed essentially a series of 40 online talks, and it became known as the Aspire Digital Program. What did COVID do also? Well, it had a massive effect upon the delivery of our examinations. You will remember from one of the slides that I gave previously is that to get your certificate of completion of training, you need to sit and pass the fellowship exam for the Royal College of Surgeons of England. The exam is run by the Joint Committee on Intercollegiate Examinations, which is a cross-college body essentially from the Royal College of Surgeons of England, Edinburgh, Glasgow and Ireland. So there was major change in how we delivered the exams. We got rid of all patients. The exams were only delivered in the Royal College of Surgeons of Edinburgh. There was a huge safety mechanism put in, but it was felt that the exams did need to get back up and running because that was the way that we were going to maintain training and maintain the pathway of our surgical trainees into consultant practice. So there was a huge amount of work that was done by John McGregor in those days, who's a surgeon from Scotland, and he was chair of the JCIE at that time. But it led to changes that haven't been reversed. So patients on the whole have been removed from the vast majority of the exams, and there's been change. So these changes have sort of lasted, as it were. What was the effect on training? Well, these are some information on logbook data, so the number of operations that the trainees were doing. So you can see the graph here at the top left that the yellow line is the emergency operations that are done. The blue line are the elective planned operations that are done. And this is for vascular surgery. So as we move from December 2018 to March 2020, you can see at the time of COVID that there was a significant reduction for the first wave of COVID from the point of view of the number of elective procedures that were done. And then there was a second wave in the UK in December of 2020, January 2021. So you can see that there were marked reductions in the amount of elective operations that trainees were doing. But the other thing to notice is that this was pre-COVID and this is post-COVID. And there really wasn't a return back to the levels of elective surgical training that were undertaken prior to COVID. So we never got our trainees back doing the same volume of elective procedures. And you can see this here in this graph on the bottom. These are the different surgical subspecialties here. You can see these are this is what was happening pre-COVID, and you can see that over 2020, 2021, 2022, and 2023, that the volume of elective operating did not return to pre-COVID levels. And that's probably multifactorial. There is probably a number of reasons for that. But I think this is perhaps, again, increases the argument for where simulation may come in, with the aim of getting trainees higher up their learning curve to make the most really of the elective procedures that they are getting experience to. And what this happened was, you remember from one of the previous slides, I talked about getting a certificate of completion of training. Essentially what COVID did was it moved everybody further along. So it took longer for people to train. It took longer for people to get their certificate of completion of training, which made them eligible to be a consultant in independent practice. And one of the things that happened very similar to our Aspire Digital was that there was also for those trainees who were in basic surgical training or in core training, so the more junior surgeons, there was the development of a general surgery online learning and development platform, very similar to our Aspire program. And essentially, with the Aspire Digital and with Gold, what this led to is that there was a realization that after COVID, that a lot of the education and the generic education and training could be delivered through an online program. And essentially what has happened is that each of the subspecialties, through funding from government, have now ended up with their own online training platform. So you can see ENT, you can see cardiothoracics, plastic surgery, orthopedics, urology, neurosurgery, oral and maxillofacial surgery, pediatrics, and here we are. So Aspire Digital has now moved to what we now call Vortex, the vascular online resource for training and experience. And what I'm going to do now is just take you through a little bit of the experience that we had from the point of view of developing our online resource for training. So this is Vortex. This is the team behind Vortex. I'm the national program director for it, but the two people who do the hard work are Tom and George. These are senior trainees in the UK, and without them, this program wouldn't have got off the ground. And this is what our online platform looks like. It is run out of one of our regional deaneries, one of our regional education and training centres near Birmingham. And it uses some very simple technology. I think it's Moodle and Blue Button combined that have been combined to develop this online platform. And this really is Vortex. And what we have is a series, essentially, a series of files where you can click onto one of these and get a whole host of information about aortic surgery or carotid disease or trauma or mesenteric disease. But what I'm just going to focus on now is the Aspire program. So you remember I talked to you a little bit about our Aspire program before, where it was a series of 6 residential courses. But within that, there was in each of the courses, there was quite a lot of lecture-based work that was delivered alongside the simulation. And what we wanted our Vortex online platform to do was to really give our trainees more time to do this stuff, more time to do the simulation, more time to get their hands onto the kit that we had, so they could do operative surgery and they could practice their endovascular surgery and not spend hours on these residential courses being talked at. So we wanted to give them time in the simulation aspect of the courses. Again, I refer back to this is what our Aspire program is. with the 6 courses. So we focused initially our work on the first course, Aspire 3, which was the Introduction to Vascular Surgery training. And what we did is we used the Vortex platform and created a number of videos that moved some of that lecture-based work that was previously within the Aspire 3 course. We moved it onto the online platform. And then we also tested their knowledge both before the trainees' knowledge, both before and after their viewing of the videos. And we looked at some engagement metrics and some feedback. So we had 42 trainees that were new to vascular surgery that were coming to the Aspire 3 course. We had good engagement, with 86% of them engaging with the online information and online lectures that we put on there. And the feedback that we got and the results that we got were that the trainees really felt that the lecture-based information, the 6 lectures that we put online, were all really of good value. And what we found was that there was a significant increase in their knowledge using MCQ questions. So what we showed was that actually moving some of the lecture-based work that we did onto an online platform increased their knowledge, did what it set out to do, but it also meant that our trainees were able to focus very much on the simulation-based work when they attended the course face-to-face. What else does Vortex do? Well, the aim of Vortex really is a repository for all vascular education material. And to date, we've got over 750 participants across a wide spectrum. They're not just surgical trainees. We've opened it up to our nursing cohorts, scientists, a few consultants, physiotherapy. So a wide number of healthcare professionals are registered to our platform. We have now started to deliver some live lectures. So every 2 Fridays a month, we will provide an online webinar that is linked and aligned to the information from the curriculum on vascular surgery. And we get about 35 to 40 people attending every session. And we have started to combine some of our talks with, for example, we did a session on aortic disease with our cardiothoracic surgeons, and they obviously will get more attendees joining. There are still some issues that we've got. There are some limitations. I did mention that the hardware was relatively straightforward. It was Moodle and Blue Button, but it does itself provide some limitations. We're still working through the curriculum, so there are some content gaps within there. And we're, as always, trying to advocate for more trainees and healthcare. But I think what we found with COVID is that we've moved very much now into a digital era. It really has changed how we need to look at, I think, the delivery of surgical and medical education. And really, what we've done in the Vascular Society is that we've moved from just delivering what I call our core courses, which was this Aspire program that I've talked about, the 6 2-day residential courses, to really an evolution into a whole host of different courses that have a variety of different methods of delivery, integrating digital training with some elements of simulation. And we now cater for a whole host of different pathologies and different types of courses, from trauma, from venous disease. We've aligned with our nursing colleagues. We look at trying to develop courses for newly appointed consultants, and we're looking at digital and leadership issues. And I think one of the things that the digital evolution has allowed us to do is really to deliver a huge number of courses really at a very low financial burden. So you get very it becomes very cost effective, and you get value for money. So the whole of these courses, I don't know however many there are, 10, 12 courses, we've delivered for under £150,000, and we're getting over 500, 600 participants per year. So really, it's huge value for money. And I think certainly in the UK, from a vascular surgery is seen as the leaders in surgical education delivery in the UK. As I said, I've been very fortunate to come over to Chenitsi on a couple of times, and I was staggered by the quality of the simulation centre and the ability to provide the courses, but also the enthusiasm of the faculty to really develop that medical education. And the role of simulation is at the heart of that. And that is somewhere where I think that we can really continue to try and collaborate and move forward. It's a fantastic environment with really state-of-the-art equipment. And there is no doubt a number of challenges, and we've spoken about these from the point of view of aligning trauma, for example, both pre-hospital, in-hospital and post-hospital training within that, but also really looking at systems and looking at how teams work in the delivery of the skills from the point of view of managing patients with significant trauma within Ukraine. Myself and Ruslan have gone slightly different paths, but probably convening in the same direction. But there are courses that are out there that do teach significant, around the management of trauma. Ruslan's a ETC instructor, I'm an ATLS instructor. But there are challenges within the delivery of such courses within Ukraine. And the hope is that we can work together to continue to look at how we can perhaps teach in the trauma scenario, using the excellent facilities that are there in the simulation centre. So I've talked about the past. I've focused very much on the present, about what we're doing now. In the last couple of minutes, I'm just going to focus on the future, because I think that's exciting. That is the evolution of digital technology is really an exciting space to be in education. And it's really because of this that there's a huge amount of new technology. There's a huge amount of kit that is available, that has the ability for us to enhance the way that we teach, and teach remotely as well, which is the key, which will have significant advantages. I'm off down to the Royal College of Surgeons of England on Monday to look at the way that they can look at sim suites and really use digital technology to create environments or change the environment that people are perceived to be working in, really with more from a simulation point of view. I think immersive technology has got a significant role to play. I think the technology perhaps isn't quite there yet from the point of view of surgical training itself, but it's not far away. And I think the other key thing really that perhaps we don't look at in detail is team training. And I think that's a real area of focus from the point of view of surgery. And through the work that David Jayne's been leading on some of the healthcare technology aspect and linking that in with Leeds Teaching Hospital Trust, there is a new bill going on called Sustain, which is the development of a state-of-the-art mock surgical theatre that will be built by the summer in Leeds, that has really got a multi-purpose use from the point of view of research, from the point of view of engaging with commercialisation and teaching, but also very much from an educational role. And so I think this is exciting times for surgery and the evolution of new technology. And I think there is I think over the next 5 to 10 years, we're going to see a real ability for us to enhance the way that we develop medical education, but very specifically skills-based medical education and surgical training from the point of view of procedural training, adaptive learning, getting that haptic feedback that probably isn't quite there at the minute, and the evolution of real sort of high-tech simulators. The simulators are pretty good at the minute, but I think they're going to get better and better over the next 5 to 10 years. So just a few thoughts from me before I finish. I think technology will become an enabler, but I think as we've shown, as we've moved through the decades over time in the UK, from the point of view of education and education delivery, competency is the key thing. It's not about time, it's about what can you demonstrate. And I think we've certainly evolved that over time. I think the thing that we're grappling with here in the UK is providing trainers the time to train, and that is vital. That we are not going to develop a suitable workforce for the future unless we invest in our trainers of today to be able to train the surgeons of tomorrow. Portability, I think, certainly from the point of view of training, there's going to be increased portability by adopting the immersive technologies. And I think increasingly we do need to focus on the well-being of trainees. I think we live in a different world perhaps than the world that the more older of us have grown up in, and society's changed, culture has changed, and I think we just need to recognize that. And I'll leave you with this. We're looking to create the future of medicine in both our countries. And, the doctors that we're training today will be the doctors who will work for a significant proportion of this century. I'm happy to take questions. Thank you very much.
Yeah, Patrick, thank you very much for such a wonderful lecture and for your support that you provide to our country. Dear colleagues, please, if somebody wants to ask a question, please.
Hi there. Good morning, everyone. Thank you, Dr. Patti, for outstanding presentation as usual, and thank you for your continuous support for our Ukrainian university, for our country in general. And I have really tricky question, because one of your slides was showing that you have a discovery that students could do more, or they could present more. So could you stop a little bit more here? Because for undergraduate studies, it's really interesting when we do not rely that much on our future colleagues, but how they show there in real life, in practice. Thank you.
Sorry, could you just ask that again? Sorry, I didn't quite catch that.
It was about undergraduate students. So discoveries. Yeah. Students could do more than we thought. So how it showed on practice? Could you specify a little bit?
Yeah, because I think so. Yeah, it's interesting, isn't it? I think what we're finding is over time is that there is the basic sort of core curriculum, the basic things that every undergraduate needs to do to become to get registered, to pass the exams, to do all those sort of things. Increasingly, what we're finding is really enthusiastic students, and what we have to be able to do is to give them the additional opportunities. So that often then Leeds, and certainly within the two units that I've worked in Cambridge as well, there are providing those opportunities to explore the world of audit, to explore the world of research. There are a number of ways that can be done. So they can intercalate and do a BSc, as I said, into an allied specialty. There are a number of other opportunities within the university in Leeds where they can do take a few weeks out of their standard training and go and explore a research project, or they can do a slightly longer piece of work that isn't a BSc, but where they take a few days out per month and go and explore a slightly more specific project. So I think there are lots of opportunities for undergraduates to look at ways that they can evolve and develop. I think there are also opportunities, and I think with the way that digital work, the digital environment that we work in now, is that they can go and present their work. I think there are wider opportunities, for example, than when I was an undergraduate, to go and develop their skill set, develop their CVs, and certainly make themselves very competitive in the current environment.
Thank you for your answer.
And I would encourage them to do so. I would encourage them to, explore and seek projects and seek those opportunities that are there. Yes.
Thank you very much.
We have a
Yes,
question.
please. Please
Hello,
introduce yourself.
Hello, I'm Maxim Petruk. I'm a third year PhD student in our university. Thank you for your lecture. It was very great. Thank you for the in-depth discussion about the history of British medical education system and the nowadays situation. I wanted to ask you about your own opinion, because if I'm correct, you mentioned that you at least started part of your education under the Flexner model of education, with more focus on the basic medicines, basic studies, basic sciences of medical field. But now I shouldn't say it is weaker now. In nowadays system. I think both in Great Britain and here in Ukraine, but less time is used for this and more for practical aspects of medicine. Do you think that it is a good idea, and that in the future we will probably be less integrated in basic parts of medical sciences, at least not for people who want to study them by themselves for some projects or other reasons? Or do you think that we lost something a little bit in the development and evolution of the medical education system? Thank you.
Okay, I'll probably give you a slightly biased view because I'm a surgeon. And so I think it's difficult, isn't it? I think, medicine has evolved massively over our knowledge base on medicine has really evolved significantly over the last 30, 40 years. So what's needed to be known has increased. And I think, if I can just slightly go off track a little bit, but I think being what we call a general practitioner, which is a primary care doctor here in the UK, is really difficult because, each branch of medicine has expanded massively. So for them to know everything is just not possible. Okay. I think medical school needs to provide you with those core skills to be the best doctor that you can. And I think there probably needed to be a little bit of movement away from the basic sciences to a degree to sort of reflect that. I think me as a surgeon, certainly in UK, I don't think surgery gets taught enough within our curriculum. I think anatomy, probably the depth of anatomy that I trained in, it probably isn't the same. Whether that's detrimental to medicine as a whole, it's difficult to know. I think it probably doesn't. I don't think our undergraduates and early postgraduate doctors get that exposure to surgery that they used to do, and therefore perhaps don't see that as a career option potentially. But I think it's really challenging because of what I've said, is that the advances in medicine are just unbelievable. Just think of where we need to go at the minute. We need to look at genomics, we need to look at artificial intelligence, we need to be teaching our doctors about precision medicine, so that that probably isn't even yet particularly within the curriculums that the people are developing. So it's an evolution, I think, but we still deal with the human body, so we still need to know the basics, I think. Quite how much of that is perhaps open for discussion, I think.
Okay, thank you very much. And if I may ask one more question, it's a small question. You have one of the slides about the previous systems and about SHO, Senior House Officer, if I'm correct. And there was part of the text about the lost tribe, but you didn't start about it. What does it mean in
What was
this
the lost
context?
tribe? So within every pathway will have points where you struggle to move on to the next point, if that makes sense. So as you progress through that medical training, there are certain points where there are barriers. And back in the day, there was a barrier of progression from SHO through to, and so people were leaving certain aspects of certain specialties, and they were known as the lost tribe, essentially. We're seeing a similar problem in the UK at the minute. In fact, very similar, in as much as that the more junior medical trainees are struggling to get onto the competition ratios mean that there's a lot of competition to get onto the higher training posts. And so there isn't that smooth transition through, and that's causing a lot of problems in the UK. And in fact, within the next year to 18 months, we're going to have we are currently having a review of medical training at the minute that is ongoing, and there will be changes to medical training. So it's this cyclical thing of every 20 to 30 years, there's a change. Things change, people adapt, society changes, medicine changes, the needs of the system change in what is a public-based health system. And so there will be some changes probably within the next year in how we train our doctors.
Thank you very much.
Any questions?
Okay.
No questions from our.
Please, Anastasia.
No questions.
Hello. Thank you very much for your such interesting and
Please.
informative lecture.
Could you please turn on the camera and introduce yourself?
Sure. My name is Anastasia Bodnar. I'm a first year student at Bukovinian State Medical University. Thank you very much for your such informative and interesting lecture. I have one question about on the point of technology being an enabler. Do you believe that AI-driven feedback tools can effectively scale faculty investment, or will the human element of mentorship remain the indispensable bottleneck in surgical training?
So the way I see simulation and the way that we've used it to date is to get people advanced up their learning curve. You still need to be able to do the cases on patients. So that is the ultimate test, and that's where your trainee-trainer interface, that relationship is key and cannot be lost. I think certainly in vascular surgery, where we've used simulation, is around moving people up that initial learning curve so that they understand that process, the steps, the techniques. And we've done that both from the point of view of open surgery, but we've also done it from the point of view of endovascular surgery, so stents and those sorts of things. So for us at the minute, with the technology that we have, it's about moving people up the learning curve so that they then are, when they do get to operate with trainers in real life theatres, that they're already have an understanding of processing and there's already a degree of competency there. As the technology moves on, who knows, that might change. But I agree with you that trainee-trainer interface will always be vital, I think.
Thank you very much. And we have a question from one of our followers. What are the research steps in United Kingdom? It's the research levels.
So from the point of view of academic surgery, so there is a parallel program of that is nationally funded through the National Institute of Health Research, where at each level, so at foundation, at sort of the more what we call core training, and then at higher training, there are allied research posts that are competitive that will run a line that. So there is an academic foundation post, there's an academic clinical fellowship, and then there's an academic clinical lectureship post. So there's an academic pipeline that runs aligned with that is competitive, and certain academic units within usually the major teaching hospitals will have certain posts within that. So David is very key to that in Leeds, and there are certain specialties that will have certain academic posts that are aligned to them. Usually after the academic clinical fellowship post, you will go out and do a PhD, a funded PhD. So if you are academically minded, there is a pathway that you will follow that is parallel to standard training, yes.
Thank you. Okay. Thank you very much for joining to us. Patrick, thank you very much for such a wonderful and interesting lecture and for the discussion. Professor Jane, thank you very much for organizing such a beautiful course and inviting your colleagues to show us different aspects of medicine in United Kingdom. And we also want to thank to the Fund of the President of Ukraine for Education, Science and Sports for making this initiative, EDU Connect, UK Ukraine visiting professors. And also we would like to thank University of Leeds for constant cooperation and support of universities in Ukraine. Thank you very much. Thanks, dear colleagues. Thanks for joining. We're waiting for you next week. There will be 2 more lectures in this course. And thank you for joining an activity today. Have a nice day. Олександр Миколаївич, ви можете виключати трансляцію.